Hello and welcome. When more than two specialists are confused, it's most likely neuroophthalmology. So I came across this beautiful question and I thought it is a good opportunity to learn a few topics of neuroophthalmology. So here we go. Sit back, relax, listen, and learn. A middle aged man comes with complaints of ptosis, pupils reactive on examination. You suspect a case of isolated third nerve palsy. Which condition is known to commonly cause this presentation? A. NMO. B. Diabetes mellitus. C. PCOM aneurysm. D. Subarachnoid hemorrhage. When you look at the question, C. PCOM aneurysm is very lucrative. It stands out for us to pick, but that is not the answer. The answer here is a vascular problem like diabetes mellitus. And the reason the answer is diabetes mellitus is because we have to understand the orientation of the third cranial nerve, oculomotor nerve. The motor output of the third cranial nerve is centrally located, and the parasympathetic output is peripherally located. So, when you have a vascular problem like diabetes mellitus, where you have decrease in the diffusion of oxygen and nutrients to the interior or the middle part, which has the motor fibers, you are going to have a patient who is clinically going to present with down and out gaze, ptosis, but the pupillary light reflex will be normal, or pupils are reactive on examination because the peripherally arranged parasympathetic fibers are not affected. Which is why here the answer is diabetes mellitus. When will you pick PCOM? When you have a patient who has diplopia, ptosis, down and out gaze, and they mention that the patient has absent or diminished pupillary light reflex. That's when you pick PCOM aneurysm, because now there is a mass, there is PCOM, an aneurysmal mass that is compressing not only on the peripherally arranged parasympathetic fibers but also on the motor fibers. So both the things are affected, which is why you will have both the symptoms, motor symptoms of down and out gaze, ptosis, and you will have diminished or absent pupillary light reflex, which is parasympathetic. So if both are present, you will pick PCOM. Now about NMO, which is also known as Devick's disease. So before we learn NMO, we have to learn optic neuritis. And the reason is the most common cause of an acute unilateral loss of vision with RAPD, a normal fundus, and a swollen nerve is optic neuropathy. And the most common optic neuropathy is optic neuritis. And the most common condition associated with optic neuritis is multiple sclerosis. So when you have a patient with acute unilateral loss of vision with RAPD, you check for an MRI. And on that MRI, you check for enhancements of the optic nerve and periventricular multifocal white matter lesions, because that is suggestive of MS and you will treat the patient for MS. But if you have a patient with acute unilateral or bilateral loss of vision plus RAPD, you do an MRI, then MRI is negative for MS, then you have to check for antibodies. And the reason we check for antibodies is because we are worried about NMO. NMO, which is optic neuritis associated with a myelitis, has antibodies against the aquaporine 4 channels, which are present on the cell membrane of astrocytes. So you will have a patient who has a history of optic neuritis plus transverse myelitis, which is demyelination of the spinal cord. They can describe demyelination of the spinal cord or transverse myelitis as longitudinally extensive involvement of 3 or more contiguous vertebral segments. And that is they hinting us that the patient has transverse myelitis along with optic neuritis. We suspect NMO, especially if the MRI is negative. So antibodies against the aquaporine 4 channels, which are present on the cell membrane of astrocytes, transverse myelitis, and clinically, we would also have a patient who has area postrema syndrome. So intractable hiccups, nausea, vomiting, symptomatic narcolepsy, or if on the MRI they say there are atypical lesions. Atypical for what? Atypical for MS. If you have diencephalic lesions, which is not typical for MS, then you would suspect NMO. Again, an optic neuritis associated with a myelitis. Now, there was an old AIMS question asking which tests will you do in a patient with optic neuritis. So, first, of course, we would do an MRI. Then we would check for antibodies. Why? Because we want to rule out NMO. NMO is way more sinister than MS. And you will check sugar level. The reason you check sugar levels is because in the acute phase of optic neuritis, you give high doses of glucocorticoids, and glucocorticoids can mess with sugar levels. So these are the tests you check in a patient who presents with optic neuritis. Okay? Now, in the acute phase, in a patient with NMO, you will give high doses of glucocorticoids to treat optic neuritis. And you can also do plasma exchange or IVIGs because NMO is associated with antibodies. So you can remove the antibodies with the help of plasma exchange or IVIGs. Now, in the chronic immunosuppressant phase, where you want to prevent relapse as a prophylaxis for relapse and as a chronic immunosuppressant, you can give mycophenolate mofetil, rituximab, and glucocorticoids with azathioprine. FDA has also approved a satralizumab, which is a humanized IgG2 monoclonal antibody. So the IL here tells us that it is against IL-6. Okay, it is against IL-6, and you will give satralizumab, which is recently FDA approved, for the treatment of NMO disorders who has aquaporin 4 channel antibody positivities. Okay, there is one more IL-6 that is an exam favorite, which is tocilizumab. And the reason I'm telling you about this here is because it also has IL in the name. So that is also against IL-6. However, tocilizumab is given for rheumatoid arthritis, psoriasis, cytokine release syndrome, stuff like that. It's not given in NMO. Satralizumab is given in NMO. Okay. Now, when will you pick subarachnoid hemorrhage? Because that was the last option, right? You would pick subarachnoid hemorrhage when you have a patient who has meningeal irritation signs. So, subarachnoid hemorrhage can be caused by a rupture of an aneurysm in the brain. And the most common place where this aneurysm occurs is the circle of Willis. So, you will have meningeal irritation signs along with the third nerve palsy. So if you have third nerve palsy symptoms and meningeal irritation sign, then you pick subarachnoid hemorrhage. Another question. So we have a 26-year-old female who presents with 6/60 visual acuity in one eye and 6/18 in other eye. She has recurrent episodes of diminution of vision, which recovers with treatment on steroids. She also has a history of transverse myelitis. What is the diagnosis? Here we don't even have to try. They told us we have a patient with diminution of vision that recovers with steroid, meaning optic neuritis, and transverse myelitis straight up. We don't even have to try. It is NMO. Thank you for watching.